I can just say ditto. So I will go past first. This is the emergency department. We are the 24/7, 365 option to fighting the opioid crisis, and you've seen us, I don't know why, on the front page of the New York Times in many places, and many great, I call heroes, emergency physicians who have taken this on themselves to create their own clinics to make sure patients will go in. We see everything in the emergency department. There is nothing we do not see. We are not allowed to send anybody away. So when we talk about whether or not people have comorbidities, anything like that, I'll tell you that all of our patients have comorbidities. Doesn't mean we don't treat them for asthma or blood pressure, et cetera. Why we are separating this disease from others is really pretty apprehensible. Why focus on this? Because quite truthfully, this is where all the patients are. We had a 30% increased visits for opiate overdose in the past year. That was presented from the CDC. This is what EDs can do. We can identify patients. We can initiate treatment with buprenorphine. We can give harm reduction techniques. We do that all the time. And naloxone distribution. There are states who actually do not, even like California, allow you to hand a medication like naloxone to their patients. That's obscene. All right, so we can link people also to opiate agonist treatment, and I say agonist because that is the only treatment that has been shown to be effective. This great article, if you haven't, I think I sent it to you by Lo Rochelle, just came out in the Annals of Internal Medicine. It's from Massachusetts. It looked at over 17,000 patients who had overdosed. And it looked at years around till I think 2012 to 2014. We know that if you had an overdose death, 5% of you are going to die within the next year. We know that opiate agonist treatment reduced mortality, and we know that many of these people did not get access to care. If you look at this is from that paper, you will see, I don't know if I have a thing here, you will see the top bar is actually all case mortality. In the next year, which went up to about 5%, 4.7 to be exact. You can see that if you were on more methadone treatment or buprenorphine, that decreased your risk of death. Naltrexone did not reduce the risk of death, and if you didn't have any MOUD, then you were, right up there and dying. So what is our evidence in emergency departments? This was our study, which showed that basically you could start treatment in the emergency department and you could refer, I'm sorry, I don't know why this is doing this, and that we were 2 times more likely if we gave buprenorphine and had a warm handoff that you were in treatment at 30 days than if you got other types of things that were much higher than what most standard of care is. We also showed that this was very cost effective. Dr. Bush published this in Addiction. So what do we do with all this? We need to do something with this. So we've done a lot of implementation science, and we are doing that throughout. These are the areas we are working on. We're working on access to agonist treatment, harm reduction techniques, safe prescribing, and reducing the stigma. And so we are integrating this in our practice. I don't know why that happens. And that right now, all of our faculty, every single one of us at Yale New Haven Hospital in terms of emergency medicine have received their waiver. Everyone at Mass General Hospital has received their waiver. Everyone in Camden has received their waiver. Most people now in California are doing that. At Highland, they are doing it. At Davis, they are doing it. Why? Leadership. You tell them they have to do it, they have to do it. Why do we ask people whether they feel like it? Do they ask me whether I want to fill out the national NIH stroke scale? No, I take 6 hours of training. I have to prove it every couple of years. They don't ask me if I feel like it. All right, they don't ask me, do I feel like knowing how to give out medications? So the American College of Emergency Physician and NIDA have gotten together. We created this framework for emergency department. These are the processes that are involved, and I've given that. You can have it. I don't have enough time to go through it, but it really gives you the structural and the process and the outcomes that we expect to happen for prevention, safe prescribing, for harm reduction techniques, for treatment, and that is actually offering buprenorphine at the time. So I'll let you read those. I won't have time. Okay, so what do we need to do to advance the changes? First of all, things we're working on in emergency department is induction strategies. We know that if we can give high dose, and there are people who are doing this right now, if I give high dose, what that means is 24 to 32 milligrams of buprenorphine at this time of the ED visit. That will last for 3 or 4 days. People can get to their treatment, and that seems to be working well. Dr. Herring from Highland has been doing that. He's done over 200 cases so far, and other of us who are boarded in addiction, I wouldn't say everybody should do this, but those that's starting who have great training are doing it. We know that you need to fill up those receptors. What's happening is people are giving far less amounts of drug that is needed, medication. If you start with 2 milligrams and 4 milligrams, which these algorithms are, that's kind of like peeing in the ocean. That's not going to help. So people are going to go out, they're going to feel craving, and they're just going to they're going to use again. So we need to make sure that we're giving them adequate doses. Another opportunity for that are long-term, longer acting injectable spray burn. Hopefully the FDA will approve that in December. That's an option for us in the ED because at 7 days we can initiate it right away. Problems with that, again, will be in pricing because I'm not sure we can get people to use it. But again, that's a one dose for a pretty long period of time. That could save a life. What is the cost of that? Referral patterns, you've talked about, I heard earlier, things whether you go to an OTP, office-based, bridge clinics, whatever. The problem is we need them and they are popping up all over the place. And people who want to do them well, who are doing them, I've been all over the country, so whether that's Mass General program, whether it's University of Cincinnati's program, it's a Hopkins, Hopkins has a great aftercare clinic where internists are all onboarded, all waivered, and they can start treatment, and then they can parse out patients to the different community sites. They can get them on insurance. They can get whatever wraparound services that they need. But as we know, the medication is the most important thing. I'm not negating that there be something else to wrap around on some patients, but I'm telling you, you can't go to counseling when you're dead, all right? And you will be dead if you don't get medication, and you can't really get your life on par if you're not feeling better. And if you're not feeling better, you can't do anything. You can't get housing, you can't stand in line for food stamps. So you have to feel better. And we know that if we can do this, we often save lives all the time who are overdose. But if we observe them and send them home, if you had an MI and I send you home and say, too bad, here's some places, you might be able to find them on Monday, but maybe your insurance won't work, that's not going to help. I need to treat them right then and there, and I need to facilitate that referral, and I need to send them on so I can keep a life so people can then get a life. We need lots of pain medicine management. We need development of non-opiate pain meds. Of course, those of us in EDs like to stick needles in things. We do that really well, and we've learned how to do it. We do it in intra-articular hip fracture so the elderly don't have to have opiates because that makes them fall off the bed and break the other hip. So we have lots of issues that we deal with. We're trying to test different treatments for patients who present that are on Suboxone and on naltrexone. It's very hard to be in a major trauma and be on those medications. Basically, I have to put a breathing tube down you because I have to somehow get away from your pain. It's not easy. I have to use ketamine, all kinds of other things. These are the policies that we need. We need these waiver courses to almost go away or be very specific because I can teach you how to do that. I teach people how to open chests in less period of time. I don't get this. We need availability of longer acting. We need methadone to be available to addiction specialists in primary care settings who are addiction specialists. We need to increase the workforce, so we need GMA slots for addiction fellows. I am boarded in addiction, and I do a lot of work with that, and we need that, and we need eligibility for them to get loan repayment programs, so we increase that. I think I'm just about, we need to talk about words. We can talk about that during the thing. Words do matter. People need to understand addiction. If you understand addiction, you would know how to treat it. All right, these are websites we have developed. You have those, so it has everything that we need. And that's basically it. This is what is out in Oakland, and I'm hoping to put this in my ED. When you walk into triage, it says, do you need help with pain pills or heroin? We don't need to screen. We just need to put that sign up, and people will ask you for help. So this is our option. We want to change the trajectory of.
Thank you.